When cholesterol is borderline, you wait and watch, right? And when it's sky high and paired with symptoms, you act, right? So BAT levels work the same way. Not every patient needs treatment, but some can't afford to wait either. That's why we use clinical profiles, not guesswork, to decide who to monitor and who to move forward in the protocol. And yes, even with limited insurance coverage, there's a clear way to justify it. At BATWatch in our practice, we group patients into two main categories: average risk and elevated risk. Average risk patients have no symptoms, no family history, no major lifestyle contributors. In these cases, we recommend monitoring annually, just like we do with cholesterol and A1C. But elevated risk patients are different. They may have mild symptoms or a strong family history or past exposure to inflammatory or metabolic stressors like smoking, drinking, vaping, or concussion, or persistent fatigue or brain fog. For these patients, the cost of waiting exceeds the cost of acting. And that's where medical necessity comes in. We're not looking for reasons to overtreat. We're looking for clarity. In elevated risk patients, it's clinically appropriate and medically justifiable to gather biological data early, especially when patients are in their 30s, 40s, or 50s, where subtle changes may be building silently over time. This isn't speculative testing. This is targeted surveillance. We also recognize not every insurance plan covers advanced testing up front. That's why we follow a structured, stepwise approach that aligns with clinical standards and cost considerations. And yes, I get it. Nobody wants to do multiple trips to the lab. In a perfect world, we'd like to get all this done at the same time in one visit, but we don't live in a perfect world. So to make sure testing costs are covered for patients and to avoid hitting them with unnecessary bills, we follow a specific order based on the medical necessity and specific insurance guidelines that each patient has. I mean, it's not ideal, but it's the best way to protect both patient care and their cost. If a patient receives a positive result on their initial screening, we don't immediately move to a deeper panel unless it's warranted. And in many cases, we repeat the same screening to confirm the result, especially if it was borderline, before taking any further steps. This aligns with most insurance carriers, and it allows us to reduce the risk of false positives, avoid unnecessary costs, and gather enough data before recommending further evaluation or any treatment. And when further testing is needed, we prioritize labs that are both medically necessary and likely to be covered, so patients aren't left with those unexpected expenses. Everything we do is guided by our three core principles: clinical relevance, cost effectiveness, and patient-centered care. We don't overtest. We test with a purpose, and we can work within the system without compromising care. So how do we justify testing and retesting when insurance coverage is limited? Well, we start with the symptoms: mild word loss, forgetfulness, fatigue, anything that raises a concern from neuroinflammatory or metabolic drift. And then we document why further testing is appropriate. Based on the patient history and presentation, brain-based metabolic dysfunction could be suspected. And in this case, testing would be necessary to look at underlying contributors and inform treatment decisions. We also use initial testing to establish a baseline, and we use post-treatment testing to document objective improvement, just like you check and recheck A1C, for example, after a GLP-1 treatment. We recheck BAT levels to confirm the effect of a short treatment cycle. This not only validates the intervention, it builds long-term trust in outcomes. This isn't guesswork, it's data-driven prevention. Because we built BATWatch not to be about a single test. It's a longitudinal system designed to adapt to each patient's needs over time. So no, not every patient needs treatment today. But when a patient's risk is elevated and their biology reflects some change going on, we have every clinical and medical justification to act. And that's not over testing. That's thoughtful preventative care. Knowledge is power. Keep watching more.